So, what effects tumor has on the host? Anyone can anyone guess what can a tumor do to the host? It doesn't always kill. It can kill. A malignant tumor can kill. But can a benign tumor kill? Malignant tumors can kill. How does malignant tumor kill? Metastasis. Metastasis. It can go to various organs. It can metastasize either blood-borne or lymphatics or perineural or direct spread. That's how tumors can kill. Okay, that's one of the characteristics of malignant tumors. But can a benign tumor be lethal? Can a benign tumor be lethal? If yes, how? So, I'll show you some pictures. So, what is this? What is this? This is the brain and various other organs. So, what does it prove? Hormonal effects. So, tumor will have a hormonal effect. Next one, before and after, what is this? This one is getting crushed. So, what is it? Why is it getting crushed? Because pressure is applied from both sides. So, a tumor can have pressure effects. Local and hormonal effects is one. Point number 2 is pressure effects. Point number 3, what is this? This looks normal. This looks thin and emaciated. So, what is that? Huh? Not exactly atrophy. There's a specific term for it. Atrophy, because the mechanism is different. Yes, cachexia. Cancer cachexia. Okay, the person will become thin and emaciated, lose muscle, lose body fat, etc. Okay, and the fourth one, which is by far the most important because multiple organs are affected, this one, you may not guess it by looking at the picture, but this is paraneoplastic syndrome. Paraneoplastic syndrome is by far the most important thing that you must remember to be at your fingertips. Doesn't mean that you're not going to know about the others. So, this is the tumor effect on host. What impact a tumor has if a human being has, what impact the tumor has on the host. Or saying the other way, if a human harbors a tumor, will the person live with it? Will the person die with it? There are certain tumors, example lipoma, but rather humans die with a lipoma rather than of it. Means lipoma doesn't kill, but if a lipoma becomes liposarcoma, it can kill. So whatever it may be, that doesn't mean that benign tumors has no effect. So these are the points that remember. Local and hormonal you can club together. Local effects, hormonal effects you can club together. Then you got erosion and destruction, cancer cachexia, and paraneoplastic syndrome. This paraneoplastic syndrome, again I'm telling you, I thought it's most important. So it has a local and hormonal effect, then it has an erosion and destruction because of pressure. You got cancer cachexia, the person becomes thin and emaciated because he or she loses muscle fat and muscle and fat stores. And then you got the paraneoplastic syndrome. If there's some spelling mistake, please forgive, I'll rectify it. Okay. So coming straight to location, local and hormonal effects. Local and hormonal effects. Location is crucial. Location is crucial. Remember, not only malignant tumors kill, but benign tumors can also have an effect which can indirectly kill you. Which can indirectly kill you. It have an effect which can indirectly kill you. The malignant tumors, you know how malignant tumors can kill a human, but that doesn't mean that local your benign tumors are absolutely harmless. They can inflict harm in an individual. For example, a pituitary adenoma, which is small, a small pituitary adenoma around 1 centimeter in size, which is absolutely benign and may have no hormonal effect, apparently can destroy the normal surrounding tissue. It can have a pressure effect on the normal surrounding tissue and it can cause hypopituitarism. It can also put pressure on normal pituitary, a small pituitary adenoma, and it can cause hypopituitarism. Hypopituitarism may not kill directly, but it can have effects on gumpacha. It can have effects. Okay, fine. Then, in case of other endocrine glands, a tumor, whether it's a primary to the endocrine gland, metastatic to the endocrine gland, can totally destroy the endocrine gland, causing endocrine insufficiency. That is one thing. In case of gut, when we study, these are just examples I'm giving. There's nothing much to for here. So, guts. For example, let me draw a picture. Okay, this is a gut. Okay, large intestine, a colon. And if a tumor occurs over here, say in the large intestine, in the colorectal region, basically, what is this basically? What is this? What is this basically? This is the anal canal, for example. Say this is the anal canal. This is the rectum here, and this is the colon. What is it? It's a blockage. It's a block. So what is it called? It's an obstruction, right? So what will happen in this case? What will happen in this case? What will happen in this case? The fecal matter cannot come here. The fecal matter accumulated over here, all the fecal matter, which cannot pass down because of an obstruction. And this will help the patient, this will force the patient to take investigations where he or she is going to discover that he or she has a gut obstructing malignancy, gut obstructing tumor. Okay, so obstruction is one thing. Then it can cause intersusception. Intersusception is something that you will study in surgery. What happens is, in case of intersusception, say there is a tumor over here. There is a tumor over here, and the peristaltic movement of the gut will bring the normal intestinal segment and the gut, causing obstruction, something like this. This is known as an intersusception. You will study that in surgery. Don't break your head on it right now. So obstruction and intersusception of the gut. Remember, some gut neoplasms, in case of causing obstruction, this is called a very good. It causes constriction of the gut, and because it causes constriction of the gut, the patient cannot pass stool, fecal matter. The person cannot defecate. The stool starts getting accumulated in the colon, causing abdominal distension. That's when the patient seeks intervention, and the patient realizes that after doing all the investigations, the patient realizes that he or she has a cancer, and treatment starts. The prognosis of these tumors are better than some tumors which do not cause any obstruction but permeates diffusely. The patient will not have symptoms until the later stages when seeking intervention doesn't help. The tumor has spread far and metastasis. So these are certain things that you will know, or maybe you have, Madam has told these things in metastasis. So gut obstruction is one thing. Remember that. Then coming to the pancreas, a small beta cell adenoma in hands can secrete so much insulin that it can cause a fatal hypoglycemia. It can cause fatal hypoglycemia. So look, remember the beta cell adenoma, then pituitary adenoma, about the endocrine glands, okay? Coming to next pressure effects, the erosion and destruction. Just remember this heading. If you remember this heading, it's very important. For example, expansile pressure on any tumor. It can be skin, it can be the gut where the tumor is so, it literally penetrates the surface and spreads far and wide, which can cause ulceration and secondary infection. That's clear, I think you can get it. If the tumor is too big, it can rip the surface apart. It can be a skin surface, it can be in the kidney, it can be in the gut, and it can spread far and wide. Okay, that's basically a local spread of the tumor. What it can do is, because of this, there will be bleeding. Obviously, there will be bleeding. And it can also invite secondary infection. For example, in case of gut neoplasm, it will cause blood in the stool. What is it? What is the term? Blood in the stool. Melena. It's a gut neoplasm, melena. Melena, I'm writing the meaning of melena here. Melena means blood in stool. Melena means blood in stool. Blood in stool is very common in case of gut neoplasm. Remember, in gut neoplasm, blood in stool. Okay. Remember, in large intestinal cancers, sometimes an elderly patient who presents with anemia, if not proven otherwise, is taken to be granted as a neoplasm of the large intestine. Okay, you will see that line is given in Robbins. Then hematuria. Hematuria means what? Blood in urine. Blood in urine. Blood in stool is melena. Blood in urine is hematuria. Hematuria is very common where? In case of RCC. One of cardinal features of RCC, perhaps the most costovertebral pain, then pain in the loin and gut, your hematuria, blood in urine is one of the most characteristic features. That is, there's a triad. There's a triad, like cardinal features of inflammation, these are cardinal features of RCC. And out of those three features, the most important is blood in the urine, hematuria. Hematuria is very common in case of UT neoplasm. I've written urinary tract neoplasm, but urinary tract neoplasm is more, in which UT neoplasm it's more common? RCC, renal carcinoma, means cancer of the kidney. Okay, so expansion, erosion and destruction, there will be expansile pressure on any natural surface. It can be a gut, it can be a skin surface, okay? So, if it's in the gut, the tumors will cause what? Blood in the stool, called melena. And if it's the RCC, for example, in case of urinary tract neoplasm, renal cell carcinoma, the most common is what? Hematuria, blood in urine. I'm giving a few examples. Okay. Then coming to cancer cachexia. This one is important. You can see how cachexic the patient looks, thin, emaciated. There is loss of body fat, lean body mass, loss of muscles and loss of body fat, weakness, anorexia, anemia. But these patients have elevated BMR. The basal metabolic rate is increased. Food intake, they have an increased BMR and systemic inflammation. Okay, so cancer cachexia এই features গুলো মাথায় রাখতে হবে. The first three are most important. Lean body fat. Okay, loss of body fat, lean body mass, loss of body fat. The fat stores depleted, the fat is depleted. Then you get lean body mass because the muscle is wasted. Right? Weakness, obviously, if you lose fat, if you lose muscle, you automatically become weak. Okay? Then you get anorexia. You don't feel like eating anything. Anemia, but elevated BMR. With anorexia, you get elevated BMR and systemic inflammation. Okay, so this picture says you everything. You can make out how cachectic the patient looks. Remember this point. So what contributes to cancer cachexia? The most important thing is TNF, red in inflammation, TNF, tumor necrosis factor, which are either secreted by the tumor cells themselves or secreted by the macrophages. Secreted by the tumor cells themselves or they are secreted by the macrophages. What it does is, it mobilizes fat from the adipose stores. Kotha kotha fat thakte pare. Legs e, thighs e thakte pare, abdomen e thakte pare. Right? Jekhane fat ache, it mobilizes the fat from its normal stores and it also suppresses appetite. It also suppresses appetite. Right? That's why the patient becomes, the patient gets anorexia. Then you have interleukin 1, other than TNF, you have interleukin 1, interferon gamma, proteolysis inducing factor. Proteolysis inducing factor means what? It induces proteolysis, means the protein is broken down. It causes breakdown of the protein. Lipid mobilizing factor, it mobilizes lipid from its source. Protein is broken down, lipid is lost. The person becomes lean, the person loses body fat. the person looks thin and emaciated. Then reduced synthesis and increased catabolism. The normal constituents are not, for example, the protein, fat, they are not synthesized. The synthesis is reduced and there is increased catabolism. The patient becomes more and more cachectic. The patient looks more and more thin and emaciated. Normal theke the patient gets into abnormal in a pathologic state. Physiologically, the balance shifts towards pathology. The person is not normal anymore. Then cachexia can hampers chemotherapy. Just remember this point. The chemotherapeutic the person discovers that the person has cancer and the person is chemotherapeutic treatment. This cachexia can hamper chemotherapy, and this contributes to 1/3 of all cancer deaths. This contributes to 1/3 of all cancer deaths. Remember these points. Remember, that's why I put it up like points. So remember these points. You can write something. Whatever you learn, if you produce 20 to 30%, 30 to 40% of what you have learned, you have earned yourself enough to pass. So remember these points. For example, if you take this slide out and ask me to speak whatever I have written here, I won't be able to, nobody will be able to reproduce. We have to see and say something. Okay, if you see these points, we can say. That's how it is. Simple. We can't remember everything, so neither you can remember everything. Whatever you learn, produce 30 to 40% of it, that's enough. It's very difficult to produce more than that. Okay. Photogenic memory. Then comes paraneoplastic syndrome. This is by far the most important thing, but I'm too all for explain paraneoplastic syndrome. Are boi ache. Sayon, boi ache. Boi ache re. So, paraneoplastic syndrome kintu benign case dekha jay na. Remember, paraneoplastic syndrome is always seen in case of malignant neoplasm. Paraneoplastic syndrome is seen in case of neoplasm. Okay. These are symptoms that cannot be explained by anatomic location of a tumor. These are symptoms that can explain. I'll explain you when I get into details of paraneoplastic syndrome. These are symptoms that cannot be explained by anatomic location of the tumor. For example, small cell carcinoma of the lung producing Cushing syndrome. Small cell carcinoma of the lung producing Cushing syndrome. Mane lung ekta tumor holo affect korche pituitary ke. It cannot be explained by anatomic location of the tumor or by elaboration of the hormones indigenous to the tissue of origin. Elaboration of the hormone indigenous to the tissue of origin. This is the definition you must write. Paraneoplastic syndrome is a syndrome which occurs in case of malignant neoplasm, and it cannot be explained. The symptoms that paraneoplastic syndrome produce cannot be explained either by anatomic location of the tumor, means where the tumor is located, or by elaboration of the hormone indigenous to the tissue of what is indigenous to the tissue of origin. Tissue there, tumor ta ache. So this is by far the most important definition, and this is taken from Robbins. Don't go for any other definition. Okay, don't look into SlideShare and all. Onek ulto palta lekhe okhane. Okay, do not go to SlideShare and any other things. Read from a standard text book. Okay, so it occurs in around 10 to 15% cases in middle-aged to elderly persons. 10 to 15% of cases, which age group is affected? Middle-aged to elderly persons. And clinical manifestations may be lethal. Okay, so why should we know about paraneoplastic syndrome, or what importance it assumes? It may represent the earliest manifestation of an occult neoplasm. It may manifest an earliest manifestation of an occult neoplasm. Keno occult bola hocche? What is the meaning of the word occult? What is the meaning of the word occult? Huh? Ki? Huh? Jore bol. Dekha dicche na. So what is it? Dekha dicche na. Examiner ke bolle hobe na. You must use a proper term, hidden. Hidden neoplasm. Dekha dicche na ki abar? Dekha dicche na mane ki to girlfriend naki? Dekha dicche na? You must use the proper word, hidden. So it may represent the earliest manifestation of an occult neoplasm. Say the patient presents with Cushing syndrome. And the doctors are thinking, okay, it can be a Cushing syndrome, the pituitary is affected. The person must be thinking in that terms. But no, the person has a cancer of the lung, which nobody has detected. Nobody has even guessed that it could be a cancer of the lung, a small cell carcinoma of the lung, which is so deadly, which needs immediate intervention. That's why I'm saying it's an occult neoplasm. It may represent an earliest manifestation of an occult neoplasm. 2, it may cause significant clinical problem, aage bolechi, and it can be lethal. Number 3, it may mimic a metastatic disease and confound treatment. It may mimic a metastatic disease and confound treatment. So remember these 3 points, okay? So when we classify neuromuscular, like classification would be endocrinopathies, like affecting the hormone. Then you get dermatological. Number 2, you get neuromuscular, osseous, hematologic, and others. Endocrinopathies are by far the most. Endocrinopathies means affecting the hormones. Endocrinopathies. Then you get neuromuscular. Number 3 is dermatological, means skin. You get osseous, means bones and joints. Hematologic. Hematologic, you know what is hematologic? To blood and others. Okay, এই পয়েন্টগুলো কিন্তু মাথায় রাখতে হবে, ডিভাইড করতে হবে প্রপারলি. হরমোনস, bones and joints, nerves, means neuromuscular, nerve and muscles, skin, blood and others. এই ক্লাসিফিকেশনটা কিন্তু করতে হবে, এই জিনিসগুলো কিন্তু এই সিস্টেমগুলোকে আমাদের করতে হবে. So locating cancers in paraneoplastic syndrome, organs involved. Which organs involved? Lungs, pancreas, neural, breast, kidney, liver, ovary, soft tissue, thymus. So these are the organs which are involved in case of a paraneoplastic syndrome. Paraneoplastic syndrome কিন্তু বুঝতে একটু অসুবিধা হতে পারে. You have to read it because you are totally new into it. Paraneoplastic syndrome. So which organs are involved? Locating cancers in paraneoplastic syndrome, organ wise, lung. আমি সবসময় লাংয়ের এক্সাম্পলটাই দিচ্ছি, স্মল সেল কার্সিনোমা অফ দ্য লাংস, স্কোয়ামাস সেল কার্সিনোমা, ব্রঙ্কোজেনিক কার্সিনোমা, এটসেট্রা এটসেট্রা. Lung, pancreas, nerves means neural, breast, kidney, liver, soft tissue, ovary, and thymus. These are the organs which are most commonly involved in case of a paraneoplastic syndrome. Okay. Now this is the thing that you must remember. Endocrinopathies. The first and foremost thing is endocrinopathies. Endocrinopathies we call it ectopic. Ectopic. We call it ectopic. Means what? Ectopic. What is ectopic pregnancy? Tubal pregnancy. So what is it? মানে প্রেগন্যান্সিটা কোথায় হওয়া উচিত? সেখানে নয়. Exactly. It's located somewhere else. এই এখানে নাইলাম কি করে পড়াবো? কোথায় যায় ছেলেটা? হ্যাঁ? সব মনে থাকে? So the most common syndrome is Cushing syndrome. দেখেছিস? Cushing syndrome can be because of, for what? Secretion of ACTH. So Cushing syndrome can be because of increased secretion of ACTH. Corticotropin. corticotropin, the precursor for corticotropin is, remember this point, the precursor for corticotropin is, দেখতে পাচ্ছ melanocortin. Precursor for corticotropin is pro-opiomelanocortin. Now this corticotropin, it can be secreted in case of a pituitary involvement. It will be secreted from can be secreted from the pituitary, but in case of paraneoplastic, the pituitary is not involved. The pituitary is not involved. Which organs are involved? For example, lungs, small cell carcinoma of the lung, or squamous cell carcinoma of the lung. One example is in case of paraneoplastic syndrome. So, patients with Cushing syndrome, if the pituitary is involved, will have increased corticotropin level. But patients with paraneoplastic syndrome will have increased corticotropin level as well as increased pro-opiomelanocortin. This pro-opiomelanocortin is not present. The pro-opiomelanocortin is not present. Last slide. In patients with pituitary involvement. Remember. So, if we divide it as Cushing syndrome, because of involvement of pituitary versus syndrome, there will be increased corticotropin. And pro-opiomelanocortin. Melanocortin is not present. Pro-opiomelanocortin will not be present in patients with pituitary involvement. There lies the difference. Okay. Then other tumors which can also cause paraneoplastic endocrinopathy, not only small cell carcinoma of the lung, which is by far the most common, then pancreatic tumors and certain neural tumors. Okay, pancreatic carcinoma and certain neural tumors can also cause paraneoplastic syndrome. And what is the mechanism? The thing which I have explained, ACTH or ACTH-like substance. It's not possible to remember everything. Remember the important ones. I'm going to touch the important ones. Then you get hypoglycemia. Hypoglycemia is more common in ovarian carcinoma, fibrosarcoma, and other mesenchymal sarcomas. Why? Because it produces insulin or insulin-like substances. What will insulin do? Insulin will bring down what? Not a beta cell adenoma. Remember, আমি একটু আগে explain করেছিলাম location of beta cell adenoma of the islets of Langerhans can also cause fatal hypoglycemia. But beta cell adenoma is benign, so it cannot be included in paraneoplastic syndrome. Right? So, which tumors can cause ovarian carcinoma, fibrosarcoma, various other mesenchymal tumors can produce insulin or insulin-like substances and cause fatal hypoglycemia. Then you get hypercalcemia. Hypercalcemia means what? Don't say metastatic calcification here. Don't make a mention of metastatic calcification here. Okay, hypercalcemia can be because of which tumors? Squamous cell carcinoma of the lung, breast carcinoma, renal cell carcinoma, etc., etc. These can cause hypercalcemia. Now, remember these points. What can be the cause of hypercalcemia? Increase parathyroid hormone, very good. Increase parathyroid hormone, primary hyperparathyroidism, it can be secondary hyperparathyroidism, right? That is one thing. কিন্তু এটা কিভাবে হচ্ছে in case of paraneoplastic syndrome? See, and hypercalcemia can be because of one, increased osteoclastic activity in the bone, right? That can be one thing. Increased osteoclastic activity can be because of a bone tumor. Increased osteoclastic activity can be because of what? A bone tumor. Bone tumor be primary to the bone or metastatic to the bone. Primary to the bone means which one? Multiple myeloma, you get osteosarcoma, chondrosarcoma. These are all tumors which are primary to the bone, and there can be metastatic to the bone. For example, in case of prostatic adenocarcinoma, diffuse breast cancers in advanced stage can do a diffuse skeletal, advanced breast cancers can do a diffuse skeletal metastasis. But this is not a paraneoplastic syndrome, mind it. This is not a paraneoplastic syndrome. Paraneoplastic syndrome is when as he has mentioned, parathyroid hormone. Here also something similar to parathyroid hormone is secreted. Something similar to parathyroid hormone is secreted. PTHRP. Parathyroid hormone related protein. Parathyroid hormone related protein, a protein which is very similar to parathyroid hormone, known as PTHRP. PTHRP is secreted, which is a humoral calcimic substance, and production of PTHRP must be demonstrated. Remember, excuse me, osteoclastic activity because of bone tumor, whether primary to the metastatic to the bone, is never paraneoplastic syndrome. Paraneoplastic syndrome is when you demonstrate a humoral calcimic substance. A humoral calcimic substance. This humoral calcimic substance is what? A substance which is very similar to parathyroid hormone, PTR, parathyroid PTH, parathyroid hormone. It is known as PTHRP, parathyroid hormone related protein. Parathyroid hormone related protein is a humoral calcimic substance which has many similarities to parathyroid hormone in the N-terminus, in the G protein coupled receptors that they share, and parathyroid hormone like protein is secreted by say for example the keratinocytes, breast, muscle, ovary, many normal tissues secrete this product. So there is increased production of parathyroid hormone. Parathyroid hormone like protein, and this PTHRP is important. It has to be demonstrated to say that it's a case of paraneoplastic syndrome, not a case of say a bone tumor, primary or metastatic to the bone. Hypercalcemia sekhaneo hoy, but that is not paraneoplastic syndrome. Paraneoplastic syndrome, hypercalcemia associated with paraneoplastic syndrome is when you demonstrate a substance known as PTHRP, parathyroid hormone related protein, which has to be demonstrated. Okay, so which are the tumors which secrete? Like squamous cell carcinoma of the lung, I've mentioned breast carcinoma, renal cell carcinoma, and adult T cell leukemia lymphoma. So, and other than PTHRP, there will be secretion of, there can be secretion of TGF alpha. Okay. Then TNF, human necrosis factor, interleukin 1, etc., etc. Okay, but the most important one is PTHRP. That is important. Then you get involvement of the nerve and muscles. Nerve and muscles. Okay, in nerve and muscles is immunologic. Means antigen reaction, antigen antibody reaction. So basically, antibodies which are against antibodies which are directed against tumor cell antigens, which should react actually against tumor cell antigens instead of fighting against the tumor cell antigens, they cross reaction with neuronal antigens. So the mechanism is, yeah, it's written here. Immunologic mechanism. Immunologic mechanism. Okay. Antibodies which would actually react against the tumor cell antigens, they cross react with neuronal antigens, normal neuronal antigens. That's why it's an immunologic mechanism, an antigen antibody reaction. So the patient presents with disorders of the central and peripheral nervous system, for example, a polyneuropathy, then you get myasthenia gravis, a myasthenic syndrome like myasthenia gravis, polymyositis, a syndrome which is equivalent to or similar to polymyositis, then cerebellar cortical degeneration. Okay, so these are the symptoms that you must remember. These are the symptoms that the patient presents with, and the mechanism is immunologic. So which tumor causes it? Bronchogenic carcinoma. Again, lung is, that's why I've mentioned lung in the topmost position. Various thymic neoplasms, breast carcinoma, etc., etc. Then what are the other things you get? Not so important. Dermatologic disorders like acanthosis nigricans. Acanthosis nigricans is a genetic disorder which is commonly seen in young adults and sometimes middle-aged adults. Okay, but in case of this acanthosis nigricans, in case of paraneoplastic syndrome, these are nothing but blackish gray hyperkeratotic patches over the skin, seen in case of gastric neoplasm, lung carcinoma, uterine carcinoma. Sometimes the neoplasm, sometimes the symptoms in the skin, the signs and symptoms over the skin comes first before discovery of the lung cancer, before discovery of the occult neoplasm. Okay, so this is the dermatologic manifestation, acanthosis nigricans, then dermatomyositis, etc. Then osseous, articular, and soft tissue changes, bones and joints. In bones and joints, you get what? In bones and joints, you get hypertrophic osteoarthropathy. What is hypertrophic osteoarthropathy? What is the meaning of the word hypertrophic osteoarthropathy? Means formation of bones, formation of new bones, especially the long bones, especially the end of the long bones, tarsals, metacarpals, phalanges, where you get what is it called? Hypertrophic osteoarthropathy, formation of new bones at the end of the long bones and metacarpals, metatarsals, phalanges. Then you get clubbing of the fingers. So, clubbing of the fingers can be seen in, for example, in bronchiectasis, cyanotic heart disease, etc., etc., in various conditions. But hypertrophic osteoarthropathy is virtually not seen in any other condition than paraneoplastic syndrome. Clubbing of the fingers can be seen, but not hypertrophic osteoarthropathy. No new bone formation will be seen. Then you get arthritis of the joints. So in bones and joints, the three things that you get is hypertrophic osteoarthropathy, formation of new bones. Then you get arthritis of the involved joints and clubbing of the fingers. Clubbing of the fingers. Okay. Then you get various vascular and hematologic changes. Tricho syndrome, from venous thrombosis, also known as Tricho syndrome. Okay, migratory thrombophlebitis. You may have read in hemodynamic disorders in case of thrombosis and embolism. You have read about Tricho syndrome. Okay, migratory thrombophlebitis. Then disseminated intravascular coagulation. DIC is very important. DIC is very important for you. Then you get non-bacterial thrombotic endocarditis and all in various neoplasms. Neoplasms are more or less similar and not explaining it, okay? And finally, you get nephrotic syndrome in various other cancers. So this is important. The ones that I have told you, I have written on the board, these things has to be mentioned. One is the endocrinopathies. In endocrinopathies, please make a mention of at least the Cushing syndrome, hypercalcemia and hyperglycemia. Polycythemia. Polycythemia is why? Because of increased erythropoietin production. Because of increased erythropoietin production. Okay, so in endocrinopathies, these are the things that you must mention, make a mention. Then in nerve and muscle syndromes, then, of course, hypercalcemia. In endocrinopathies, please make a mention of hypercalcemia. Then in nerve and muscle syndromes, the mechanism is immunologic, anti and antibody reaction, tumor cell antigens versus the neuronal antibodies. Instead of reacting against the tumor cell antigens, will react against what? The neuronal antigens. Then you get dermatologic manifestations like acanthosis nigricans, dermatomyositis. Then bones and joints, osseous, articular and soft tissue changes, hypertrophic osteoarthropathy, and clubbing of the fingers and arthritis of the joints. The tumors, the years are more or less similar. Then vascular manifestations. Vascular manifestations. What do you get in vascular manifestations? What do you get in vascular manifestations? Venous thrombosis or migratory thrombophlebitis, also known as Struve syndrome, DIC, disseminated intravascular coagulation. Then you get non-bacterial thrombotic endocarditis and red cell aplasia, and finally others like nephrotic syndrome. So this finishes your paraneoplastic syndrome, and rather the tumor effects on host, you have to read it. If you have any problem, you can ask, and please make a mention of the ones that I have specially mentioned on the board. It cannot be written down in, you won't be able to understand that. Okay? So clear?
It is an ill-defined, disabling, which is accompanied in many medical conditions or diseases. And it may arise due to either from external stimuli or from internal stimuli. Now, I think you have got enough knowledge about the physiology of pain, physiology and pathology of pain, how the pain is being formed, how the information has been transferred to the cortex and other region, and what is the reaction of the cortex according to that. So all of you have got that knowledge right now. Yes or no? Yes or no? So can I skip that, or I have to recapitulate it in short? That is the pathway of pain, because unless you know the pathway of pain, you won't be able to understand the action of opioid analgesics. Okay, pain has got two components. One is the nociceptive component and another is the affective component. What is nociceptive component? What is nociceptive component? It is some sort of disabling sensation which can arise due to some noxious stimuli. And the information is carried to the cortex via ascending pathway. And what is the affective part? It is your psychological reaction after receiving that information. Psychological reaction to the pain after receiving that signal. So these two are the component of pain. Now pain, as I told you, it is an accompaniment of many medical conditions. So from the ancient time there is pain, but at that time there was no remedy, specific remedy which can relieve the patient from pain. But there is one drug. Was available at that time, that is the opium. Opium, from where the active component of morphine was isolated later on. So opium was used. So these are the, I think, competency covered. You can write it down. Because, you can write it down so that you can know what you have to to read in this chapter. So that is the describe the mechanism, action, types, doses, side effects, indications, contraindications of opioids and opiate and agonists. You will find this in your website also. But what is the SLO? What is the learning objective? You can write down this one. Specify opiate analgesic, enlist the types of opiate receptors and response mediated, enlist the endogenous opioid peptide and their role, mention the mechanism, that is all about the morphine, mention the manifestations and treatment of opioid withdrawal syndrome, including overdose, treatment of overdose of morphine, outline the management of opioid dependence with justification, enlist opioid and other opioid agonist, antagonist, partial agonist, antagonist, and their effects and uses. And last it is a new come up, that is the enlist the peripheral mu receptor antagonist mention their uses. Last one is the most newer one, that is the enlist the peripheral mu receptor antagonist and mention their uses. Coming to the topic. So opium was used both medicinally and recreationally from very ancient times. At that time, opium and opium mixed with alcohol was being used almost to treat each and every medical condition. So that's why at that time this opium was termed as the gift of, that is the God's own medicine or God's own medicine. It is, the term was coined by Sir William Osler. God's own medicine. This is a picture at that time who is procuring that this opium from this plant. Now, there are some important definitions and you have to know, because in oral it is very, very important. First of all, what are analgesics? Analgesics are the drugs which relieves the pain either by central or peripheral mechanism. Without it you must tell it, without alteration of consciousness. If it alters the consciousness, that will be general anesthetic. Next is the opioid. Any drug which reacts with opioid receptors, those are known as the opioids. Next, opiates. Opiates, the drugs derived from the opium are known as the opiates. Example, morphine, codeine, Priven. These are the examples of opiates. Next is the most important, narcotics. What do you mean by narcotics? These are the drugs also which can cause relief of pain. But in addition, what it does, opium-like compounds with potent analgesic effect. But it is not only that. What it does contain, apart from these, are associated with alteration of mood and behavior. And also on chronic use has the capacity or capability to produce dependence and tolerance. So, drugs derived from opium or opium-like substances which has got potent analgesic effect associated with alteration of mood and behavior and with potential for dependence and tolerance on chronic use. So, these are the important definitions and you have to know all these. Next is the what is pathway of pain. They have seen that there are two components, nociceptive and affective component. And what are the mediators of this pain pathway? What are the mediators? Substance P, NMDA, that is the glutamate, bradykinin, and prostaglandin. Now, pain arises in the periphery and it will be conveyed to the spinal cord, dorsal horn cell, there is a substance gelatinosa through the primary afferent neuron, which is contains two types of fibers, as you know, A delta and C fiber. Low threshold A delta and C fiber, where they sign up and form the joints with the spinothalamic tract. Spinothalamic tract, it is of two types. One is the neo-spinothalamic tract. It will go through the medulla, midbrain, and ultimately to the somatosensory cortex. That is known as the neo-spinothalamic spinothalamic tract. What it does? When the information reaches here, that you will be able to know the character and localization of the pain and what you have to do. Either you can withdraw, or if it is due to noxious stimuli, you can take some measure like as for example drugs. Another is the paleo, that is from the, it goes to the limbic cortex. It reflects the psychological response towards pain. And there is another pathway that is known as the descending inhibitory pathway. It is very, very important. Descending inhibitory pathway from the PAG, that is the periaqueductal gray matter in the midbrain, then rostroventral medulla or nucleus raphe magnus in the medulla, and ultimately to the spinal cord, dorsal horn cell of the spinal cord. What is the function of this pathway? How? It will release some, that is the metencephalin and norepinephrine, and thereby it can inhibit the ascending pathway. Now here you can see that some asterisks. These asterisks are the sites where the opioid receptors act. Now how this descending inhibitory system will be activated? In the midbrain, that is the PAG, how it will be active? Inhibitory control of GABA. Normally there is presence of GABA. And here is the opioid receptor. What is that receptor when they are stimulated? What it does? It will inhibit the release of GABA. So that pathway will be out of control of inhibitory effect of GABA. That means the inhibitory system will be activated, and that will lead to the periphery, that is the release of enkephalin and norepinephrine, which can inhibit the ascending pathway. This is in short the pathway. And in the spinal cord, how they can inhibit the excitation of the ascending pathway. You can see that is the peripheral afferent nerve fiber, the C fiber terminal. There is presence of mu opioid receptor, and how these excitatory transmitters are released with the help of activation of the calcium channel. This calcium is the driving force to release the excitatory neurotransmitter like glutamate and benign. All these are. Now what happens? New opioid receptors, they inhibit or block this calcium channel, and thereby inhibit the release of the excitatory neurotransmitter. So there is inhibition of the ascending pathway stimuli. And another mechanism is in the postsynaptic pathway. There is potassium channel. There is activation of the potassium channel. Potassium channel will go out, so there will be hyperpolarization of that postsynaptic site. As a result, there will be inhibition of the ascending pathway. So these are some sort of recapitulation of your knowledge regarding the pain pathway. Endogenous opioid peptide. Morphine, the opioid receptors, there are mainly three types of receptors: mu, kappa, and delta. They are isolated long ago. But whenever you find one receptor in our body, there must be some endogenous ligand. As for example, adrenergic system, alpha receptor. There must be some endogenous ligand in the form of norepinephrine. Say for muscarinic receptor, so endogenously liberated ligand is the acetylcholine. So what these receptors are there? At that time, no endogenous ligand was identified. So is it for the discovery of morphine later on, and morphine will be administered, then the opioid receptors will be activated? It is not possible. Another example is mainly in the battlefield, when a soldier suffered a grave injury, but you can find that he can tolerate the pain. He did not perceive the pain at much intensity. What is the cause? So there must be some endogenous substance which, by interacting with the opioid receptor, causing this inhibition. So these are known as the endogenous opioid peptide. A soldier does not feel pain even sustains severe injury. These are the biological molecules found within the brain that act through the opioid receptors. And they are derived from some precursor. Those are the precursor also for the hormone. As for example, pre-opiomelanocortin. It is a precursor of which hormone? Pre-opiomelanocortin. Cortisol, ACTH. It is a precursor of ACTH. So, derived from protein family, that is a pro-hormone, and its existence was unproven until 1970. Until 1970. So, there are different peptides. Originally, there are three peptides were isolated: beta endorphin, enkephalin, and dynorphin. Beta endorphin, you can see that high affinity for the mu receptor and derived from POMC. Then enkephalin, it is a composition of two, that is the met and liu enkephalin. Now they are highly sensitive to the delta opioid receptor, and found in many parts of the CNS, peripheral nervous system, and the gastrointestinal tract. Next to the dynorphin, it has got high affinity for kappa receptor, dynorphin. So it has got some association with the nociceptive transmission. Now, later on, the fourth receptor was isolated or identified, invented. Fourth receptor, that is the, and that receptor has got no similarity with the, if in comparison with the other three opioid, that is the endogenous opioid. That's why initially that receptor was termed as orphan receptor. But later on, the endogenous peptide was identified, that is the nociceptin and or orphan F2, and they are associated with the some reward stress responsiveness and drug technology and memory. If you know this much, that will be sufficient for endogenous opioid peptide. It may come as a short note. Now these main three receptors and some important characters. Mu receptor has got almost all the effects, starting from analgesia, respiratory depression, euphoria, but it cannot produce dysphoria. Mu receptor does not associated with dysphoria, and meiosis, sedation, constipation, much amount of physical dependence and reward. So all are can be seen with mu opioid receptor stimulation. Kappa receptor, it has got some analgesic effect, but the most important is the dysphoria. You can see that. Kappa receptor is associated with dysphoria. And others are, that is a sedation, all these meiosis can also occur. Whereas in case of delta receptor, you can see that motivational effect and reward, constipation will be there. And some spinal analgesia will be there with the delta receptor. So you have to know that the kappa receptor is mainly associated, only associated with the dysphoria. No other opioid receptors can cause dysphoria. Now these opioid receptors are the G protein coupled receptors, and these G protein coupled receptors are inhibitory in nature, and ultimately they can cause, that is, you need not know all these details. Now classes of analgesics. There are two types of analgesics mainly. Number one, non-narcotic analgesics. This can cause relief of pain without alteration of mood and behavior or no development of tolerance or dependence like this. So these are the NSAID. What is the full form of NSAID? Non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs. Example is the aspirin, ibuprofen, diclofenac, sodium. So many drugs are there. Next is the narcotic analgesics, of which morphine is the prototype. Why this term? That is the morphine. It is derived from Morpheus. Who is Morpheus? It is the god of dream. Morpheus is the god of dream, and morphine can cause euphoria and so many things, behavioral changes. That's why it was named as morphine by Sartner. It was named as morphine by Started in 1830. So morphine is the prototype of all opioid analgesics. So can you tell me what do you mean prototype drug? What do you mean by prototype drug? Prototype. No. What do you mean by prototype? Often you will find in many different classes of drugs, all drugs are not being discussed in detail. And we used to tell, and in the book you will find that morphine is the prototype drug of opioid analgesic. So what do you mean by prototype drug? Anyone from this class? What do you mean by prototype drug? Hmm? Huh? Loud. In a group, there are so many drugs. It is not possible to go through all aspects of each and every drug from that group. Then we will be mad. So what we will do? One drug has been selected which possessed all the activities of the drug from that group. Main activity. And that drug is considered as the prototype drug. And other drugs are discussed in comparison with the prototype drug. Okay, that is the prototype drug. So, how morphine name has come, that is the Morpheus. And what is the source of morphine? Very stock question in oral. What is the source of morphine? Morphine is an alkaloid. Morphine has got natural source. Then what is the source of morphine? Opium. First off you have to say opium. Then you will be asked, what do you mean by opium? Opium, you have to listen carefully. Opium is the sun-dried, milky exudate obtained by incising unripe poppy capsule of the plant Papaver somniferum. So you have to tell all these. Opium is the sun-dried, milky exudate obtained by incising unripe poppy capsule. Study all throughout the night. Please listen. It is a very important drug, important chapter. And that is the Morpheus, god of dream. And what is this? Can you understand this fellow? One of the important character of matrix, Morpheus. Now, classification of opioid. You may be asked, give some examples of opioid drugs. As I told you, opioids are the drugs which can bind with the receptor. So it may be agonist, it may be partial agonist, it may be antagonist, it may be natural, it may be synthetic. So all are included in this opioid analysis. I am not discussing all these. So this is the morphine analog and synthetic derivative. You can see that yellow colored drug, you have to know each and every aspect of the yellow colored drug. That's why here morphine, in the antagonist naloxone, in the phenylpiperidine synthetic group, pethidine, fentanyl, mostly fentanyl, ramifentanil, and in methadone series, most important drug is the methadone and dextropropoxyphene. Benzomorphan series is the pentagocin and cyclagocin. Why pentagocin has been withdrawn or not used nowadays, we have to know. And next is the semi-synthetic derivative of the partial agonist buprenorphine. And there are miscellaneous drugs. That means they have got the capacity to act through opioid receptor, and in addition they can act through some other mechanism. That's why they are termed as miscellaneous. Of the most important drug is the tramadol, most important opioid analgesic used nowadays. Apart from this, there are others like loperamide, diphenacylate, and dextromethorphan. But they have got no relation with analgesia. They are used for some other purpose. Now, to the classification of opioid analgesics. First of all, natural alkaloids, obviously morphine and codeine, then semi-synthetic derivative. Here the most important is the falcodine and buprenorphine. Falcodine and buprenorphine. Next is the synthetic derivative, the phenylpiperidine, as I told, pethidine, fentanyl, remifentanil, methadone series, methadone, dextropropoxifen, and benzomorphan series, pentazocine and cyclazocine. So these are the examples of opioid. These are the examples of opioid analgesics. And lastly, tramadol, and the most newer drug in this group is the tapentadol. Tapentadol. Now, what are the different actions of morphine? It has got central action, it has got peripheral action. What are the central actions? First of all, most important action is the analgesia. Acts mainly through mu opioid receptors, but it has got action also through kappa and delta receptor too. Kappa receptor euphoria করে না dysphoria করে, কিন্তু kappa receptor is associated with dysphoria. Now, it has got some other effect on, it can cause some analgesic property. Next, what types of pains are relieved? Dull, poorly localized pain is relieved more. Dull, poorly localized visceral pain is mainly relieved, but reduced effect on the neurotic or somatic pain. There is alteration of both perception and reaction. Alteration of both perception and reaction due to pain stimulus. And it has got propensity to produce euphoria. Euphoria, as I told you, you can see that, but it makes us dysphoria with due to kappa receptor stimulation. There is one drug, pentazocine. It is a powerful kappa agonist. That's why when it was came, it was a very good drug, widely used in anesthetic practice. But later on, it was seen that it can cause dysphoria that will lead to some other complications. That's why it was withdrawn. Next is the sedation, central effect. So these are all the central effects. Number one, analgesic, euphoria, and sedation. Now, what is the mechanism of analgesic effect of morphine? What is the mechanism of analgesic of morphine? It acts to opioid receptors. It acts to opioid receptors, which are G protein coupled receptors. It has got supraspinal component, spinal component, and some sort of peripheral actions too. GI, inhibitory, G protein coupled receptor inhibitory, not S. So it activates mainly mu opioid receptor at periapical gray matter at where midbrain. It activates the descending inhibitory pathway, which acts via rostroventral medulla to substantia gelatinosa in the spinal cord and release norepinephrine and 5-HT serotonin that will inhibit the ascending pathway. Attenuate the dorsal horn excitability, and by which these are the accompaniment. Increase the pain threshold, decrease the emotional reaction to the patient, induces sleep, euphoria, tolerability will be increased. If you give morphine to a patient having intense pain will be there. Patient will say that pain is there, but it is not distressing me. I can tolerate this pain. So this is the supraspinal component. Next is the spinal component. One is the effect of the activation of the descending pathway. So there will be decreased release of the excitatory neurotransmitter. I told you how it will happen. It is due to the blockade of the calcium channel. There will be decreased release of the excitatory neurotransmitter. Next is the hyperpolarization of the postsynaptic neuron. It is due to activation of the outward potassium channel. If the cell is hyperpolarized, so it cannot be excited. So that will also help in the analgesic effect. And this spinal effect mainly done by kappa opioid receptor. Also there are some new next is the activation, that is the peripheral component. So it has been seen that they can cause some sort of local anesthetic effect. So that means you are asked about the mechanism of action of morphine as analgesic, you have to start from it acts to opioid receptor, which are inhibitory type G protein coupled receptor, inhibitory type G protein coupled receptor. And what are the action manifestations of G protein coupled receptor inhibitory type stimulation? Number one, decreased cyclic AMP, decreased cyclic AMP, decreased release of the excitatory transmitter, and decreased inactivation of the calcium channel. All these the accompaniment of the GI type of G protein coupled receptor. Next, what are the supraspinal component? That is the activation of the descending pathway. Activation of the descending pathway at the level of the PAG and rostroventral medulla, and that will lead to connect to the dorsal horn cell, where it will act via release of enkephalin, 5-HT and norepinephrine, and they attenuate the dorsal horn cell excitability. This is the main important. Then the additional effect is the CNS is the euphoria, increased tolerability, and sedation. So these are the supraspinal effects. Next is the spinal effect. It is the secondary effect of the activation of the descending inhibitory pathway. Decreased release of the second is the decreased release of the excitatory neurotransmitter, and all these mainly done by kappa receptor. And the third is the peripheral component. There is some sort of local anesthetic effect. So this is how morphine will relieve pain. What are other effects? Other central effects. Respiratory center, respiration, depression. But in ordinary therapeutic dose, you won't find respiratory depression. You won't find respiratory. It can be seen in higher dose, or it can be seen in elderly people. It can be seen in infant. It can be seen in infant. Respiratory depression. The respiratory center will be depressed. And another is the, if there is hypoxia, accumulation of carbon dioxide. What is the stimulus for stored carbon dioxide? Is the increase in ventilatory drive. That is the increase the respiration rate. That is being blunt by the morphine. So there will be respiratory depression. Next is the cough suppression. The central action, cough suppression. Next is the vasomotor center. It is also depressed in high dose. It is also depressed in high dose. Vagal center also it will be vagal center. It will be stimulated. It will be stimulated. The effect of vagal center stimulation, bradycardia. Then meiosis, mu and kappa receptor. But mind that repeated administration of morphine or opioid can lead to tolerance. But there will be no development of tolerance in meiosis. That means in chronic opioid addict person, if it comes, you can identify that with the help of that is the pinpoint people that the person is an opioid addict. So meiosis, there will be no tolerance. That is the meiosis you can see here. Vomiting center, CTZ will be stimulated, and that will lead to nausea and vomiting. Then heat, thermoregulatory center, where it is situated. Thermoregulatory center, where it is situated. Next, CNS, there might be excitation in the form of convulsion, and that is seen mainly in the neonate or infant, and also in the elderly person. That there might be convulsion. Now coming to the peripheral action. Peripheral action, most important is the GIT. Morphine addicts, they are habitually constipated. Morphine addicts, they are habitually constipated. What is the mechanism? You can see that there will be no development to these effects. So meiosis and constipation, there will be no development of tolerance to the morphine. যতদিনই খাক না কেন কিন্তু meiosis আর constipation হবেই। Next is the how. By decreasing the motility and propulsive movement of the intestine. Motility and propulsive movement of the intestine, these are the driving force, that is the peristaltic movement for normal purgation. So that is being lost by decreasing the motility and propulsive movement, but the basal tone is increased. Another important finding is the decreased secretion, decreased intestinal secretion. So stool will be hard and difficult to pass, constipation. So there are drugs which are used, morphine was used at one time for the treatment of diarrhea. How it will be effective? By this mechanism. By these mechanisms, it was used previously for the treatment of diarrhea, and there are certain drugs nowadays available, as for example, loperamide. I told you in the classification, loperamide, diphenxylate sodium. They are, even nowadays they are used in diarrhea condition. And how they are effective? Like by this mechanism. In biliary tract, it increases the biliary tract pressure. So if you give morphine to a person having acute biliary colic, what will happen? If you give morphine to a person or lady having or suffering from acute biliary colic, what will it? Does it help the lady? Morphine increases the intrabiliary pressure, but morphine is an analgesic drug. It can reduce the visceral pain. A lady comes with acute biliary colic, and you have injected morphine. What will be the sequelae? What will be the effect? The pain will be aggravated much more. So, morphine is contraindicated in acute biliary colic or in any form of undiagnosed abdominal pain. Next is the genital urinary system. There will be urinary retention. Reflex will be inhibited. External sphincter will be spasm, and detrusal muscle will be contracted. So there will be retention of urine, but patient cannot pass urine. There will be urgency, but patient cannot pass urine because the sphincter is closed. That's why don't give morphine to a person having benign hypertrophy of prostate. Benign hypertrophy of prostate gland. Next is the salt and water retention. Salt and retention. It is due to ADH hormone. Morphine can কি করে হবে? ADH বাড়লে না কমলে হবে? Water retention বাড়লে হবে. Morphine can stimulate, but there are other drugs in the opioid group. They can decrease the ADH. Another important function is the bronchial muscle. Now, normally there will be no effect, but in high dose and in certain persons, the persons having COPD, chronic obstructive pulmonary disease, persons suffering from chronic bronchial asthma, there will be strong bronchoconstriction and there will be aggravation of the symptom. And why this bronchomuscular, that is a constriction? It is due to liberation of histamine. Morphine is a powerful histamine liberator. One of the sequelae of histamine release is the bronchoconstriction. Endocrine system, neuroendocrine system, sex hormone. They are decreased in male ACTH, testosterone, and gonadotropins will be depressed. In female, gonadotropins will be suppressed or depressed. And there might be signs and symptoms of suppression of sex hormone. If the morphine is given in early, that is the puberty or like this, there will be several manifestations of suppression of hormone secretion, sex hormone secretion. ADH and oxytocin kappa receptor agonist decrease, but morphine may promote ADH secretion. As I told you that there are some drugs which can cause decrease in the ADH secretion, but most a powerful stimulus for ADH secretion. Oxytocin also be increased by some drugs. But morphine can reduce the oxytocin, and thereby it can prolong the labor, and thereby it can prolong the labor. So uterus, the effect of morphine is that may prolong the labor, and lastly, that is the immune system. There might be suppression of immunity if the drug is continued for a long time, mainly seen in addicted persons. Mainly seen in addicted persons. Now, another stock question: what are the centers stimulated by morphine? Now, you can tell me what are the centers stimulated by morphine? It is a very stock question, stock oral question. বলো ভেবে বলো কোনটা কোনটা স্টিমুলেট হয়? মিয়োসিস কি? এটা পেরিফেরাল অ্যাকশন তো না। মিয়োসিস কেন হয়? মিয়োসিস কেন হয়? oculomotor, third cranial nerve. So third cranial nerve stimulation. আর bradycardia কেন হয়? vagal effect. So vagal center will be stimulated. আর কি হয়? nausea and vomiting. CTZ. So these three centers are stimulated by morphine. And what are the centers inhibited by or suppressed by morphine? What are the centers? Number one, vasomotor center. Number two, cuff center. And number two, cuff center are the thermoregulatory center. And of course, the respiratory center should be written in the first part. So respiratory center, vasomotor center in high dose, cuff center, and thermoregulatory center are suppressed by morphine. Now, what is the effect of morphine on the cardiovascular system? It is a peripheral effect. What is the effect of morphine on cardiovascular system? As I told you, morphine is a powerful histamine liberator. অটাকয়েড আরম্ভ হয়েছে না? অটাকয়েড আরম্ভ হয়েছে? হিস্টামিন হয়েছে? হিস্টামিন হয়েছে? What is the effect of histamine on the vascular system? Constriction, dilation, peripheral vasodilation. So there will be peripheral vasodilation, fall in blood pressure. Fall in blood pressure. আর কি হয়? Blunting of the baroreceptor mechanism. আর vagal effect, there will be bradycardia. Vagal effect, there will be bradycardia. So these are the effects on the cardiovascular system, and it is not usually seen when the patient is in supine position. But if the patient stand up, he may fall down, or he may feel dizziness, vertigo. That is due to postural hypotension, and all this due to the secondary effect to liberation of histamine. Liberation of histamine. Something about the pharmacokinetics: it can be absorbed almost all routes: oral, subcutaneous, intramuscular, rectal, parenteral, and also through spinal route. Freely crosses the placenta. It should not be administered in the pregnant lady. Should not be administered in the pregnant lady. Metabolized in the liver by glucuronide conjugation. Metabolized in the by glucuronide conjugation. Now this conjugation reaction, it is what type of metabolism? You have read the drug metabolism. There are two types of phase 1 and phase 2. Conjugation, where phase 2. Conjugation is a phase 2 type of reaction. So half-life 2 to 3 hours, route of administration: oral, rectal, parenteral, spinal, epidural, and also transdermal, but not through morphine, but the opioid analgesic can be given through transdermal patch. Transdermal patch. What is it? PCA. I think this year it has come as a short note. patient control analgesia. Patient control analgesia. What is that? It is here it is only shown in the spinal or epidural type. But this patient control analgesia can be given subcutaneously, also intravenously. Now this type of administration, patient has got no control regarding the manipulation of the concentration of the drug given. It is already programmed by the doctor. Programmed by the doctor so that 24 hours pain control will be there effectively. 24 hours pain control will be there effectively. How? It has got two parts. One is the cannula. One is the catheter has been introduced in the spinal canal. Catheter is being introduced into the spinal canal, and that catheter is connected to a infusion pump which is implanted subcutaneously. And it is programmed from the beforehand. How much amount of the drug will be released per minute or per second. So patient has got no control, and by that, what you can do, when there is pain, patient will ask the caregiver that I am having very much intense pain. Caregiver then find out the medicine. He or she will draw the medicine, then he will inject, and it will take some time to act. So that gap can be minimized by this type of mode of administration. So that means it is suitable for chronic pain and pain of terminal illness. Also, it is widely used to relieve pain during labor and post-operative pain. And what are the advantages? Better pain control, reduced absorption. Morphine is slowly absorbed, so there is less chance of adverse effects of morphine. Yes. What are the adverse effects? There are therapeutic dose. You can see the respiratory depression, sedation, meiosis, vomiting, constipation, and due to liberation of histamine, you can find itching, urticaria, swelling of lips. And due to liberation of histamine, again there will be hypotension and bronchial spasm. And in chronic case, lead to tolerance, that is the development of tolerance in many of the effects of morphine, especially euphoria analgesic sedation, but not to meiosis and constipation. Next is the cross tolerance, that means the tolerance to the other group of opioid analgesics. Then physical dependence. There is a craving for the drug. There is some sort of behavioral disorder leading to obsession and compulsive use of drug, and that will lead to dependence. That is the addiction. Treatment of acute poisoning. How will you find? There are three triads. Coma, pinpoint people, respiratory depression. Coma patient, unconscious patient brought to the ER with pinpoint people and respiratory depression. Most common diagnosis is the opioid analgesic due to overdose of opioid analgesic. What is the treatment? Supportive measures if there is a severe respiratory depression, care of the respiration, care of the vascular system, and then specific treatment, and that will lead to number one, gastric lavage with potassium permanganate. Any alkaloid poisoning, gastric lavage with potassium permanganate should be done. Remember it. Any alkaloid poisoning. Then opioid antagonist specific, there is fortunate enough, we have got specific opioid antagonist, that is the naloxone. What is the dose? We have to remember it. 0.4 to 0.8 milligram intravenously repeated every 10 minutes. Up to 10 milligram of the drug can be given in 24 hours. 10 milligram of the drug can be given in 24 hours. Head injury debo na, keno debo na? Head injury keno debo na? Bari debo ar ki? Prognostic sign will be blunt. Prognostic sign from the symptoms of brain damage will be blunted. So false impression. Ar ki? Ar kothay debo na? acute abdomen, undiagnosed acute abdomen, আর কোথায় দেবো না, BPH, benign hypertrophy of the prostate gland, আর কোথায় দেবো না, bronchial asthma, হ্যাঁ, bronchial asthma দেবো না, chronic kidney, ওটা তাও দেওয়া যায়, অতটা কন্ট্রাইন্ডিকেশন নেই। Now let us see, there are so many contraindications. 5H and 3B. 5H and 3B. What are those 5H? Head injury, hypotension, hypertrophy of the prostate, hypothyroidism, hepatic disease. So these are the 5H where you should not give morphine. Then 3B, bronchial asthma. Then one is the baby, another is the biliary colic, another is the baby. So these are the 3Bs and 5H where you should not give or administer morphine. Withdrawal syndrome. Withdrawal syndrome. Morphine has the capacity to cause dependence. Dependence ki? Some sort of adaptation which may lead to withdrawal syndrome when there is cut off from availability of the drug. That will lead to withdrawal syndrome. What are those? In acute, the symptoms are two types of symptoms: somatomotor, autonomic activation, significant somatomotor and autonomic activity, and number two is the affective part. Somatomotor is the may lead to agitation, hypertension, hyperalgesia, hyperthermia, dilation of the pupil, lacrimation, all sorts of will be there, diarrhea, nausea, and coughing and sweating. So remember that is the agitation, hypertension, hyperalgesia, hyperthermia, pupillar dilation, and secretion. All the secretion will be increased. So this is the due to the somatomotor and ANS activity. Next is the affective part. What will be dysphoria, anxiety, and depression. These three are the affective symptoms of withdrawal syndrome: dysphoria, anxiety, and depression. How will you treat? To cut the autonomic supply. Clonidine, alpha 2A agonist. You know that if we stimulate the alpha 2A receptor agonist in the presynaptic region, it is an autoreceptor. It will inhibit the release of the norepinephrine. But the recent drug is the lofexidine. It is also an alpha 2A receptor agonist, but lacks the hypotensive action of clonidine. So it is much useful nowadays for the treatment of withdrawal syndrome. Now for chronic case, another weak, less potent opioid analgesic methadone is the drug of choice. Weak, less potent methadone is the drug of choice. Effect থাকবে কিন্তু কম, so that the withdrawal symptom can be controlled. And after that, if you can, after some time, some days, if we withdraw the methadone, there will be no withdrawal symptom. Why? Because methadone is a very weak and less potent opioid analgesic. So this is all about the withdrawal syndrome. And some drug interaction, almost all CNS active drug, it has got important drug interaction, sedative hypnotic, all the it will be sedative hypnotic effect will be exerted. And in case of antipsychotic tranquilizer, you can see that CNS effect, sedation and respiratory depression and acceleration of the cardiovascular effect will be there. MAO inhibitor, that is due to the hyperpyrexic coma. MAO inhibitor, hyperpyrexic coma and hypertension will be there. So this is the important drug interaction with some important drugs. Clinical uses. First of all, analgesic. Where you have to give morphine. Number one, in severe visceral pain, you will be asked, name some condition, acute myocardial infarction. Acute myocardial infarction. Now, why? What is the beneficial effect of morphine in acute myocardial infarction? Number one, relief pain. Number two, there will be decreased preload, decreased chronotropic activity, decreased inotropic activity. So, that will decrease the determinant myocardial oxygen demand. In myocardial infarction, there is decrease in the myocardial oxygen supply. So, that is the important actions of morphine, why it is given in acute myocardial infarction. Postoperative pain through PCA in some frightened situation. Frightened situation, that means a man suffered a road accident, compound fracture, you have to give morphine. No other analgesic drug. It can be given in acute, it is drug of choice in acute left ventricular failure because it is a vasodilator, mainly venodilator. So, decrease in the preload, that will lead to beneficial effect in acute left ventricular failure. In acute LVF, morphine is the drug of choice, and sometimes some opioids are used in pre-anesthetic medication.